Welcome this morning or afternoon or evening, wherever you are. Thank you for joining us today. This is the second in a two-part series of listening sessions around men and contraception. The series is sponsored by the Male Contraceptive Initiative, and my name is Dominick Shattuck, and I'm a public health researcher who focuses on masculinity, gender roles, and their influence on health outcomes, which includes reproductive health outcomes. So I'm currently an associate scientist at the Johns Hopkins Bloomberg School of Public Health, and I'll be moderating today's session. So our goals for today are to listen to the reproductive health and policy experts on how to better engage men in their own reproductive health and family planning, to explore gaps and opportunities in the current contraception landscape that will humanize the field, and ultimately to prepare for the introduction of novel male contraceptive methods into our health system. Part one of the series was held last month and focused on an evidence base for framing contraception via redefined masculinities and gender norms. And you can find a recording of that session on the Gender Equity Unit's YouTube channel. We'll be sharing some links around that. The introduction of new male contraceptive methods is said to offer several advantages over female contraception alone. This includes improved reproductive autonomy, reduced risk of unintended pregnancies, and increased gender equality in family planning. We can also begin to think about how conversations about contraception and family planning may change. First, in the clinical setting, also at the policy level, and last in relationships when these methods are introduced. Several male contraceptive methods are now in development, and initial market research suggests that there will be significant demand when the methods become available. And today's discussion includes three clinical researchers and a policy analyst who have extensive experience working with men, interacting with policymakers, and thinking about this monumental change that introducing new approved male contraceptives will have on our society and health system. And so with all of that stated, I'd like to introduce today's panelists. First, please meet John Amory. John, can you give us a wave? And John works as an attending physician at the University of Washington Men's Health Clinic, and he is the Associate Dean of Translational Science at the university. John's published more than 200 peer-reviewed papers and chapters in male reproductive health. And his work focuses on the development of novel male contraceptives and improved treatments for men with infertility and testosterone deficiency. Next up is David Bell. Dr. David Bell, an adolescent medicine physician and the medical director of the Young Men's Clinic at Columbia University since 1999. This clinic focuses on primary care for adolescent and young adult males, emphasizing high quality, respectful services, including sexual and reproductive health. David is a past president of the Society for Adolescent Health and Medicine and co-founder and board chair of the Partnership for Male Youth. In addition to his academic and clinical responsibilities, David is actively involved in research focusing on adolescent health. Welcome, David. We also have joining us today is Brian Gwen. He's an associate professor of obstetrics and gynecology at the University of Southern California. Brian is a program director for the Fellowship in Complex Family Planning and runs the Emerge Lab at USC, which Emerge stands for Expanding Male Engagement in Reproductive and Gender Equity. He's published on topics including men's access to emergency contraception, the underutilization of vasectomy, and cisgender men's experience of abortion. Dr. Gwen is currently focused on developing new male contraceptive methods and is a co-investigator for the international multi-center clinical trial of a topical, not tropical, hormonal male contraceptive gel. He additionally conducts research on men's willingness to use male contraceptives as a consultant for the WHO. And now I'll introduce Adam Sonfeld, who's owner of the Sonfeld Policy Solutions. And Adam provides consulting services on healthcare policy, sexual and reproductive rights. And he has extensive expertise on Medicaid and private insurance coverage for reproductive health services, the Title X National Family Planning Program, and religious and moral exemptions to providing coverage and care. He worked for 24 years at the Guttmacher Institute, serving as executive editor of the organization's policy analysis work, and as policy analyst, advocate, writer, editor, researcher, and spokesperson, which are a lot of different hats. So he had a lot of responsibilities as a bookmarker, and he's going to share some of that great experience with us today around policy related to male contraception. Thank you all for being here with us today and bringing your perspectives and all that experience to the room, which is critical. So just a little bit of housekeeping before we jump into the conversation. We have Terry Laban with us today, and Terry is a graphic note taker from Breakthrough Visualizations. You can see his pen is the cartoon of his pen and hand in the image. And Terry he'll be capturing key points and ideas covered during today's listening session. You can pay attention to some of the little changes he has across the visualization during the event. So thank you for being here, Terry. The next 45 minutes will be a conversation among the panelists based on their vast knowledge of the field. And the chat will be open for audience members to add your thoughts and pose questions for the panelists in that chat. So links for resources mentioned will be posted, and panelists will field audience questions for the last half hour of today's session. The session will also be recorded and shared afterward. All right, with that, let's start the conversation, and I'll try to keep my questions a little bit concise, but that was a lot of initial kind of setup here. So let's get you guys talking. As of today, 2 main contraceptives are available for men, and those are condoms and vasectomy. And there are many novel male contraceptives that are in development. The global market research has shown that most men would use male contraceptive methods at some point in the future. Yet we know that there is still groundwork to be done to ensure acceptability, feasibility, and societal change around family planning norms. So let's start by talking about what panelists are hearing from patients in the clinic and from participants in novel male contraceptive trials. So I'll start with David. Would you tell us a little bit more about the Young Men's Clinic and what you've heard from men and their experiences with PrEP and injectables to prevent HIV? And maybe how that experience might be related to the introduction of these new male contraceptive methods.
Great. Thank you, Dominick. So the Young Men's Clinic is a component of our Title X funded program for women. And since I have been as the medical director of that program, we've grown from a 4-hour-a-week service to a 5-day-a-week service, serving from 750 unique patients to close to 3,200 unique patients during the year. So one of the key concepts guys will come, the ages of the guys that I see are ages 14 to 35. So it really spans a gap of guys who are out of primary care and out of sort of healthcare in general, except for their approach to the emergency services in general. What I have found over the time, there are guys that come in and ask for male contraceptives that don't exist at the point, in the ones that they want. Like they're usually a little bit too young for vasectomies and haven't had their sexual experience. That's sort of how we frame that, is open to discussion as we are thinking about it. I know that I've been in many discussions about the decision making around when is it right for vasectomy. So, but in the context of this, a number of guys have said they know in other countries that there are male contraceptives available, which I'm not quite clear that is true, but they insist that it is. I was like, well, we hope to have ours. What I do think, though, is one of the stories that we can build upon is that the new layer of services around PEP and PrEP, post-exposure prophylaxis and pre-exposure prophylaxis for HIV prevention, we now have a model of how to increase and deliver the sort of male contraceptive care in our services. And so I think that it's many guys, obviously we've created the systems, or we've created the visits, and I think it's how we can sort of bring male contraceptives into our healthcare system.
Yeah, that experience, global experience really, of bringing men in for PrEP and also for HIV and ART adherence and using those drugs is really critical in kind of engaging men in the healthcare system. And Brian, you provide a really different perspective and experience as an OBGYN. Can you tell us a little bit more about Emerge and your thoughts about contraception and family planning as more of a human issue than a women's health issue.
Unmute myself here.
Yeah.
First off, thanks for having me. And actually, David Bell was actually one of the formative researchers in my pathway of thinking about how I was going to introduce male contraception into the field here. So I'm obviously not an adolescent medicine doctor, I'm an OBGYN. But I will say that I recognize that there's a lot of stigma that a lot of people face when trying to access reproductive health, young men especially. What are the factors that might influence someone to, do something that they might feel judged about, right? And so in my mind, well, for an adolescent male, right, who is that other than his female partner? And so that's where my work in OBGYN comes in. And I realize that one of the most influential factors for the behaviors of most men is their female partner. So as an OBGYN, I think that if I can introduce male contraception when it comes out to the female partner, then I'm going to have a very direct route with a lot of influence to young men. So that's kind of the idea there. As part of the Emerge Lab, and again, Emerge is an acronym for Expanding Male Engagement in Reproductive and Gender Equity. A lot of my work is aimed at really expanding this idea of what men are, what they're interested in, who they can be. We often have these stereotypes of men being, not interested in sexual reproductive health or apathetic, and that's certainly not the case. We certainly have men who actually are very interested, and my work aims to highlight their interest in wanting to take control of their own bodies and also be reproductively responsible.
Yeah, that's great. And I think it's really a good segue too to jumping over to John and looking at some of the clinical experience because, as you're saying, that conversation it's kind of weird for guys to have around contraception and reproductive health. It doesn't happen unless it's with a partner. And oftentimes men don't come to that conversation with a full kind of range of information either. So, John, you want to talk a little bit about the experience with maybe who signs up for these clinical trials and, what are they like? How do they, what might be similar or different from men in the general population, or kind of some of their experiences in the trial as well, and some of the things you're hearing?
Yeah, thanks, Dominic, and thanks to David and Brian. I enjoyed listening to your answers. So, I would say the men who sign up for these trials are a joy to work with. This is a population of guys who are highly motivated based on their prior experiences with contraception. A lot of men are really interested in having kind of more control over their reproduction. And then I would say a fair number of the men, especially in the couples trials, are motivated by their partner's negative experiences with female contraceptives. So they're kind of heroic, right? They're doing something new, something that's, not fully tested, and they're willing to sort of participate because they see it as a great good and a need for society. So they inspire me. I got a inbox full of people who just want to sign up for my latest trial. So I would say the enthusiasm's high. As to your last point about how do they differ from all men, that's harder for me to say. When I talk about this at cocktail parties and tell people what I do, the enthusiasm is high, especially among women. But I think society's ready for this. I'm my most important role is father of two sons in their 20s. And I would say this generation, as far as I can tell, is ready for this.
Mm-hmm. Yeah, thanks. And it's definitely good conversation and interesting because although people are aware of a lot of things that happen around reproductive health, they never really have that open conversation. And it's really key to kind of introduce that, right? So this is super obvious. I think about this space a lot, and we know that most people in the world are believing that young people should have comprehensive sex education in schools, whatever that looks like, but some kind of information and understanding as to that. And that students still don't widely get exposed to that curriculum without significant advocacy and a policy change at a federal, state, and local level. So now shifting a little bit to the policy conversation, Adam, I understand that some of the earliest guidance around insurance coverage for contraception was designed by the Women's Prevention Services Initiative to cover the full range of female-controlled, or what are called female-controlled contraceptives, which are most contraceptives, right? And while that has since been revised to include male condoms, there still seems to be a gap in language here around the way contraception is spoken about in policy circles. And can you please kind of bring us up to speed a little bit on the challenges in general and suggest ways to mitigate that for other forms of contraception, such as vasectomy and potentially these new methods?
Sure. Yeah, it is a long, complicated story, and I'll try to condense it. It is true. The Affordable Care Act, federal law passed in 2010, requires health plans to cover most contraceptives and to do so without any copays or other cost sharing. But vasectomy is not included in that, and neither would any of the new future methods for men that are in development, according to the way the law is written at the moment. That's an artifact of how the ACA was written and what the concerns were at the time. They were requiring coverage for several buckets of preventive services, starting with services recommended by the U.S. Preventive Services Task Force, which focuses on primary care providers, and also immunizations and some services for children, recommended by pediatricians. And then during the debate over the bill, they realized that a lot of services, particularly for women, were not included in any of those buckets. And so they added another bucket about preventive services with respect to women. They're talking about cancer screenings and contraception and a bunch of things related to maternity care. And there are a bunch of things that are just left out of those other guidelines. And so when the law was passed, the government commissioned a new set of recommendations to fill out those preventive services for women, and that included contraception. Because of the language in the statute, it was interpreted to exclude vasectomy and male condoms at the time. And the recommendation initially talked about female-controlled contraceptives for that reason. They eventually got rid of that female-controlled language to include male condoms. The reasoning is they can be prescribed for women, they can be provided to women, they clearly benefit women, but that's a much harder bridge to cross when it comes to vasectomy, because that's a service clearly provided to men. I was certainly one of many advocates arguing otherwise and tried to get the administrations over the years to change their mind. We have not had any success with that. That same logic would apply to the new male contraceptive options in the horizon too. And that leaves us with a real potential cost disparity between methods, female methods versus male ones. And that could lead to some bad choices that couples would have to make, where they end up, choosing a method that isn't right for them because of cost. I wrote about some ways to address this problem in a recent paper for the American Institute for Boys and Men. I think that's just been sent around as a link. There are a bunch of potential partial solutions at the federal level, at the state level, otherwise. The Preventive Services Task Force could, in theory, recommend male contraceptives or contraceptives generally, but they generally avoid the topic of contraception. As I said, they really focus on primary care provision, and this is just not something that generally has been considered part of primary care, even though it should be. Congress could fix this by changing the law, but Congress is much more likely at this point, in the current climate, to reduce or eliminate ACA benefits than to expand them. And that's particularly true for reproductive health, and I'm sure we'll talk more about that later. The states can act on this. 8 states currently require insurance companies to cover vasectomy without cost sharing. Other states could do that, but state authority is limited. The US is very weird in terms of how it regulates insurance. States can only regulate insured plans. They can't regulate self-insured employers. Those account for more than half of people in this country who get their insurance through their employer are self-insured plans, and they can only be regulated by the federal government. The insurers and the employers could just do this on their own. They could just decide to cover male contraceptives at the same way they cover other contraceptives without being forced to do so by the law. That might require some persuasion by drug manufacturers, by advocates, by state policymakers. It's possible that a new novel male contraception will add some impetus to that. You'll have new drug companies that have a vested interest, for instance, in this, but also just expanding options and getting people excited about new options may provide some more impetus for action. I think one thing to keep in mind is that policymaking advocacy requires advocates. You need organized groups to actually work on this, and we don't have that for male reproductive health. This is a very unusual panel for when it comes to reproductive health, particularly for policy. Usually I'm, one of the only men in the room, maybe the only man in the room, and we have an all-male panel at the moment. That is very weird. It's usually the providers, for instance, who are spearheading advocacy on these issues. You have OB/GYN groups, you have other women's healthcare provider groups. You don't have that built-in constituency of providers when it comes to male contraception. Vasectomies are not done by physicians who otherwise think about reproductive health. And who's going to be providing these novel new male contraceptives? Hopefully this will bring together new sets of providers who care about these issues and decide they need to advocate for their patients. But that's going to require some doing to make it work.
Right. Thanks. It shows like the complexity of this. And I know that the comment around being the only men in the room around reproductive health conversations is one I think we all have experienced, or maybe being one of two men in a big room of conversation. And it's unfortunate because not that men need to take control of that conversation, but they're part of the process. And so making sure they're part of a process in an equitable way that is making, ensuring rights for women and rights for men in this space, allowing people to make open choices is critical. And the policies are really going to be impose, big influence on that choice. Now, everyone else is a clinician on the panel, and you're all influenced by these policies. And I'm curious to know if, you want to speak, anyone wants to speak a little bit to how that influences your work on the day-to-day, or even on the bigger picture in terms of how you're managing your sites as well. And jump right in, yeah. I don't know or we can move on.
No, I mean, there's so much to build off that. From a policy standpoint, I suppose, the policies are really what are impacting how people even begin to research sexual reproductive health, right? If we know that it's not going to be paid for, right, then who's going to put in the time to do the research? One of the things I realized in pursuing male contraception was that contraception is a hot button issue for some people. And how do I step back a little bit, make this a little bit less controversial, and advocate for something that everyone can agree on, right? Which is men's sexual and reproductive health. And so when you put contraception as a package deal, it's talking about HPV vaccines, STI screening and treatment, prenatal genetic testing, all these things together, right? And so in my website, I have something called the Emerge framework where I map on all of these things all these services that we currently offer to women in the field of OB/GYN, and how they map onto relevant services for men that our system just has not caught up with, right? I think the HPV vaccine is a perfect example of that, whereby, for almost a decade, men didn't have access to HPV vaccines, even when they are known carriers of HPV and can get HPV related cancers themselves. So the fact that from a policy standpoint, we're not catching up here demonstrates that there is a pattern that can be addressed.
Right. Please
May
add.
I add? Oh, go ahead.
Yeah. Go ahead.
I just wanted to say one thing about, thank you, Adam, for that interesting perspective on payment. That's a couple steps down the road for someone like myself who's doing trials. But I did want to just throw out there that it's a surprise, I think, to many people that the main funder in this area is the federal government. So the Contraceptive Development Branch, which is part of NICHD, has funded a lot of this work over the last 30 years. Actually, and Pat Schroeder, who was a representative from Colorado, gets a lot of credit for actually writing contraceptive research into appropriations bills. I think this was in the mid-90s. So unfortunately, I think that there's a chance that that funding is at risk. And so for those of you who are interested in this field and have a chance to advocate with your representatives and so forth, I would hope that you would, remember that and potentially, if given an opportunity, advocate for continued funding for contraceptive research.
Yeah, a great point. And it's a great segue to, I'm gonna, one of this, we heard Brian talking about how it's a little bit of a reframing of reproductive health in a way. And that reframing kind of is helping us to kind of understand how to kind of incrementally, and talking about David's experience with the ARTs and the HIV prep drugs, and how these are, kind of, we have some systems in place, but it is also reframing this space a bit. John, can you talk a little bit more about how this, in a very kind of high level way, talk about how this kind of reframes research around these contraceptive methods as well?
You mean that the fact that it's federal government funding?
No, more so in like, when we think about these contraceptive methods and how research has typically been implemented, women are the endpoint, the pregnancy prevention endpoint.
I gotcha.
And now we're starting to think, well, what is the endpoint with this type
Yeah,
of?
so I see what you're getting at. Yeah, and this is an interesting topic. Most of the contraceptive trials that have been done over the last 60 years have been for women. And so there's a well-established methodology for how do you count pregnancies? How do you determine efficacy? And in the male contraceptive space, I think we've been a little remiss in that we just sort of adopted a lot of that methodology, and it doesn't really map well to men. For example, women, you can say, well, if you have a menstrual cycle every month, then you're not pregnant, and we can use that as a measure. For men, it turns out that that's not the greatest measure for several reasons. First of all, men can have more than one partner, so whose menstrual cycles do you count? The other thing from a male perspective, when we talk to men, is the way that we calculate a counting cycle for a female study is if there's one episode of intercourse in that cycle. So in theory, there's a risk. Well, it turns out one of the main determinants of pregnancy is sexual frequency. So one of the things that's going on in the male community right now is sort of thinking again about a reassessment, if you will, of how do we want to actually measure the efficacy of a male contraceptive. And there's a novel proposal out to do that based on number of episodes. So basically, what's the risk with 100 episodes of intercourse of a pregnancy? And you can actually apply that to condoms and vasectomies and come up with a number that's actually, I think, meaningful to men. So basically, if you use a condom, there's about a 13% chance of an unintended pregnancy in 100 episodes of intercourse. And we'll need to study that, actually. We'll need to see how that way of thinking about contraceptive efficacy plays with men. This is Brian. This is something I'm hoping maybe you can help with. Sort of comparing and contrasting the traditional female-centric ways of thinking about contraceptive efficacy with some of these new male methods.
Yeah, Brian, do you want to add any more from your experiences working with men and in this space?
Well, I mean, I guess from a measurement of contraceptive efficacy standpoint, I'll mention that then the entire framework is kind of ready for excuse me, a revision, in the sense that efficacy, when you study these studies, refers really just to trial settings and a single method. And in fact, the actual human behavior kind of undermines that a little bit, in the sense that some people often add behavioral methods along with their current methods. They might withdraw, they might use condoms still, they might use fertility awareness, being aware of when someone is ovulating. And then in the setting of male contraception, thinking about this idea of dual partner contraception, which I think often gets overlooked. This idea that if one partner uses one method and a partner uses another, right, you probably do have some synergistic effect here. So I do think that that also needs to be explored a little bit more. And I think that it just gives us a lot more flexibility.
Yeah, and it's a lot of really not only interesting questions, but important questions about like providing services on the back end too, right? And the advice and the guidance, right? So back to that earlier topic around the clinic and the exam rooms, want to learn a little bit more about, kind of key opportunities for talking with patients about contraception and male methods. And kind of rolling back to you, David, what are your thoughts about best practices for talking with men about their sexual health? And are there differences in your approach depending on whether they're coupled, single, monogamous, non-monogamous, heterosexual, or LGBTQ plus?
Right. I think that's a great question. I do want to add to the previous discussion in one way that early on when I joined the Young Men's Clinic, I actually did partner with the Guttmacher Institute, or they partnered with me. And one of the key on some of their research, and one of the key issues that I was brilliant that the Guttmacher Institute did was talk about sexual and reproductive health for men in their own right, as opposed to just thinking about it through a women's lens. And I think that's part of this discussion is like, this is about male contraception for in men's own rights to sort of have that ownership in this space. So back to your question, Dominic, I think that I think that there's a difference in conversations with guys in general than we have with women. In general, we can hide behind physiology when we talk with women around their menstrual cycle, whether it's present or it's not present. When you talk with males around sexual and reproductive health, you really have to be comfortable talking about sex. And so that's sometimes a bit different than many clinicians are trained. And so it's a bit uncomfortable, but as we move forward in this, we do have to be comfortable talking about sex and not talk only about the physiology around sort of reproduction. And so the conversations aren't different by groups of men in any way, shape, or form. The bottom line approach is just really asking the question with curiosity and with non-judgmental approach, and being comfortable with the subject. And they really want to talk about it. There's not really another venue that they can talk honestly about it without a lot of bravado. And so this is where our sort of clinical space really works well.
Yeah, the bravado elements and the conversation when you're having a couple of beers and the conversation in a clinical exam room is definitely different, but they both require a level of intimacy, right? They both require the clinician and the patient to kind of have some level of comfort and intimacy and being comfortable talking about these topics like you mentioned.
Yeah.
Ryan, do you want to add more from your experience as an OBGYN and seeing female patients in the clinic on a regular basis and how this influences your perspective on that counseling element?
Yeah, I mean, just speaking to my experience with the vasectomy and people who are done having, kids, is that there's a huge, discrepancy in the uptake of vasectomy versus tubal ligation or tubal sterilization. Um, and the fact of the matter is that vasectomy is safer, cheaper, and more effective than tubal sterilization. To make it more clear for some of our lay audience, a tubal ligation requires a surgery that has a incision that's done in the abdomen, and there can be damage to other structures and more bleeding, as opposed to vasectomy. And so when you hear that, it should become very clear that vasectomy is the answer. And yet here I am talking about tubal ligation with my patient. Instead, in the postpartum setting, after a woman has just delivered a baby, I can then address her male partner who is conveniently there, about vasectomy. So it's a perfect opportunity to bring that up. So that's why I encourage all my trainees to do when they visit their moms and babies after.
Yeah, and I think it's great. And anyone else have more to add? John, I see you.
Well, as I'm listening to these comments, I'm just reflecting on many interactions I've had with participants over the course of the years where there's actually sort of this real curiosity and almost a bravado about testosterone levels and sperm counts. And, most of these studies are open label. So, the men are like, oh, I made 1 billion sperm, and they do it, of course, in the Austin Powers voice. And there's a joy to this. They're really interested in learning about the bodies. And I think one of the things that's just come of late, which I think is very empowering for men, are these at-home sperm check kits. Brian and I were just able to, and others were able to incorporate this in the most recent trial. And this is really great for men and for couples because they can measure their sperm count at home. And if you're talking about a male contraceptive that suppresses sperm production, this is a very useful way to monitor. I think men really like it. They feel more comfortable relying on their contraceptive. If their sperm check is low, it looks like a little COVID test. So men are very familiar with them. They can share them with their partner, who of course is happy to see that the sperm count is down. And I think that's going to be a real boon. It's a lot easier for a man to monitor his fertility status with one of those types of male contraceptives than it is for a woman to monitor hers.
Yeah, yeah, that's great. And I was recently at the National Contraceptive meeting in Durham, North Carolina, and hosted by MCI as well. And one of the poster sessions I went to, two young researchers were talking about a model that was called the sync model, where they were basically in the intervention. They talked in the waiting room. Or as people were coming in to be seen by the physician, they were asked, do you want to hear about contraception today? And just that simple kind of initiation and starting that conversation with men who are going in to see the physician, you had a big increase in the percentage of men who actually talked about contraception with the physician in that space. So kind of that invitation is really critical to starting that level of intimacy and talking about a really tricky topic. And also, as you all said earlier, work that I've done in the past too, the role of the wife is really central to kind of, opening the door for him to start thinking about his responsibilities in a different way. And not to put it all back on her, but it's a relationship, and people, hopefully they have a good way to kind of communicate about that. So shifting gears a little bit, we can talk for a moment on the current state of reproductive access and funding in the US and how this might affect the advent of novel male contraception methods. Is there an opportunity to be strategic while the current administration is busy attacking DEI, gender equity, and reproductive rights? And I'll kind of push this on you, Adam, as our policy expert here. So you want to start us off with this conversation?
Absolutely. Although I'll warn you in advance, I am definitely not an optimist on anything generally in my life, but I'm definitely not on policy right now in the United States. It's a very difficult policy environment for anything related to reproductive health. And to be clear, that's not just about attacks on abortion. It's not just about attacks on trans rights. Many of the same anti-abortion groups and politicians oppose contraception too. Oftentimes they talk about methods of contraception being methods of abortion. They're trying to conflate those lines to help undermine them. You see that with direct attacks right now. The current administration is withholding family planning funding from numerous providers around the country. The Congress is threatening to bar Planned Parenthood from serving Medicaid enrollees and otherwise excluding them from government programs where they offer contraceptive care and other preventive services. They don't offer abortion care with federal money because that's illegal. This is about going after their services for family planning services. There are broader attacks. There are broader attacks on the Affordable Care Act, on Medicaid, broader efforts to eliminate government programs. All of that can have pretty massive spillover effects when it comes to funding for reproductive health services, insurance for reproductive services, provision of them, information about them. That includes the federal surveys and data sets that let us even identify the problems in the first place. Even to know how many people are using which contraceptive methods. They're right now eliminating those surveys without congressional authorization, by the way, just getting rid of the staff and the surveys and just, eliminating that. And without that information, we're going to be flying blind for years to come about what the problems are in this country. So yes, it is possible the advent of new male contraceptives could spark some bipartisan interest in contraceptive access and coverage and rights. I was saying before that you need advocacy groups for it, of course. But it could help to break some of the logjam around these issues that that comes from them being gendered and sexist. You know, not every attack on reproductive rights is about sexism, but it underlies a lot of this. It underlies a lot of language around how people talk about it. It underlies who advocates for, you know, for what, and yeah, making it clear that reproductive health is something that everyone should care about and benefits everyone would help. That's something that people have been trying to do for decades. It's not like this is a new thing. But you know, this may give us a new wedge to help with that. But you also have the flip side possibility. You can easily see in this climate, seeing attacks on contraceptive coverage for women because it's discriminatory against men. I mean, you saw that before. You had a lot of people talking about, my God, insurance has to pay for maternity care. I'm a man. Why should I have to pay for maternity care in my insurance plan? That was a big movement after the ACA, a big objection, and people suing over that. You know, and that type of attitude could just be, you know, dangerous for the coverage we have now, you know, as opposed to helping us expand coverage. So from that dour outlook, I'll pass along to some other people on the panel who
I'm
maybe
going to pass it over to David in a second, but those conversations are happening, and I think there's a good way to kind of address them over time. So, you know, and kind of work through the truth of those concepts, as well as kind of the reality of how those concepts play out in life, right? So, yeah, pushing it over to you, David, please.
Yeah, no, this is kind of a question for everyone, but particularly for Adam, partly because you mentioned that, well, based on sort of really misinformation about how female contraceptives work, and the concept that many people think that it's about that conception has happened and that then the contraception works by sort of taking away that sort of embryo attachment, or however the people conceive of this. But wouldn't the abortion sort of debate be taken off the table if you block sperm, because there's no conception? So it just seems like that's an opportunity.
Yeah, I mean, it's certainly, blocking sperm would be a method of contraception that no one would be able to argue is a method of abortion. That is absolutely true. And that would be wonderful that way. It won't stop, you know, the Catholic bishops, for instance, from opposing it. They oppose contraception on other grounds, and there will be other reasons people will, you know, will think about it that way. But yes, that would be certainly a positive, a little silver lining there. One thing I wanted to mention earlier that I forgot to, it is fantastic that we are all treating preventing pregnancy as a health outcome on this call. That hasn't always been the case, and there are a lot of medical bodies that really just don't see that as a health outcome. And you know, instead they've insisted that, oh, what are the downstream health benefits of preventing pregnancy? You know, what does it mean for, you know, preventing women with longstanding health issues from having that made worse by a pregnancy, you know, diabetes or health disease, heart disease, or the risk of maternal mortality or infant mortality and infant issues. There's trying to talk about pregnancy prevention as a health benefit, is tricky, because a lot of people don't see it as a matter of health. They see it as a matter of social benefit, economic benefit, rights, autonomy. And it's one of the ways that contraception and reproductive rights and health are just different from most of the rest of healthcare. And it just adds always a layer of complication to everything that we do on these issues.
Right. Yeah, that's really interesting and an important kind of perspective to keep in mind, because it does have so many more social implications in terms of, whether it's teen pregnancy or single parenthood, or, the social dynamics, as well as the economic implications of being a single mother or, needing assistance in that space. Yeah, so kind of shifting it, we're about finished here to round it up. I'm going to jump to our last kind of opportunity to give some final thoughts on what you think is needed to truly change the framework on family planning so as to be ready when the novel male contraceptives arrive. It's really critical to consider our short-term reality is, and also at the same time to plan strategically for the long term to ensure that the landscape can shift so that people of all genders have sexual and reproductive autonomy. So just kind of get some final thoughts from each of you, and then I'll move to some questions from the audience. Yeah, why don't we start with you, Brian? You're a top right on my panel. Yeah.
Sounds good. I think that what you're asking about here really segues directly into the Emerge Labs work, which is just making people pay attention to the fact that men are interested in their own reproductive health, and by infusing that idea to all people, especially students who may someday become policymakers, that is something to pay attention to. Is how I'm starting.
Okay. Anyone else?
Yeah, as I mentioned, I have two sons in their early 20s, and this generation is our target, and they access information very differently, and they think very differently about things. And I think a lot of the work that Brian's doing, and I think David is doing, sort of kind of querying young people about their attitudes, about what they want. What would they like in a male contraceptive? I mean, I've sort of had my head down working on developing the technology, and I think it's really important we engage the potential end users here to find out what appeals to them. You know, that is such a key element to this, because if we develop a perfect male contraceptive but nobody uses it, it's a fairly Pyrrhic victory.
Right. That human-centered
Yeah.
kind of approach to this is really key.
Very
And
much so.
oftentimes we don't think about that. And also in terms of like how it also impacts women and their relationship with their partners and that whole
Yeah, we should include young women in these conversations as well. How happy would they be with a man using a male
Exactly.
contraceptive?
Yeah. To you, David.
So I want to sort of bring back some language that John used earlier. We have a lot of thoughts about masculinity sort of roaming around that isn't always positive, obviously, but what John used the two words, heroic, earlier, that I think the concept that there are young men and men really willing to play an important role in contraception is important for us to sort of really put forward and highlight. The second is that we, somewhere in there's altruism. The guys actually do care about their partner's health, and they want to sort of mitigate any side effects that their partners may have with female contraception. So I sort of thinking about those two and sort of highlighting how positive men's involvement can be. And it will be the first time we'll have some tangible strategy for what we call male responsibility. So I think it'll be great.
Right. And Adam, I'm gonna push you to not focus on the negatives of those policies, but something positive here. What do you want to give me your ideal in this context?
Oh God, I had such a great negative to talk about right now, which I'll do quickly first before I give you the positive. How's that?
Yeah.
As we're talking about educating young men, particularly teens, we need to protect that information. We need to protect their ability to get that information from people who don't want to have people talk about sex to teenagers. There's a lot of people who don't want that in schools, who don't want that on the internet. They conflate that with pornography. They conflate that with all sorts of bad things, and making sure that we keep those rights is that the right to access that information is going to be incredibly important. And hopefully the fact that we're talking about it mattering to both boys and girls will make that easier. There's a little silver lining for you. I think we also have to think about the manosphere and the very weird ways that young men are being influenced on social media, and the real rise of some extraordinarily sexist ideology, and what that might mean for that you have to make sure that male responsibility and male reproductive rights doesn't end up being trampling on women's, responsibility and reproductive rights, which we've certainly had some threats of in the past in terms of things like spousal consent for abortion and things like that. So gotta look out for that. But yeah, I mean, I do love the idea that the more options you have that are universal, that where these making it clear that contraception matters for everyone, it has benefits for everyone, and could be everyone's responsibility, that may be the type of thing that can really break through, and make things better in the U.S. and elsewhere, in terms of the politics around these issues. Because it just, it's been decades and we're going through the same cycle, and this might break it.
Yeah, and it is such a fine line to walk in terms of like, putting these methods out, making sure that they're promoted in a way that is equitable and informed, and kind of access is universal, as well as making sure we're not it's not a zero-sum game in this situation. It isn't. It's got to be more than that. It's got to have more positives, for society in general. So I'm going to move over to a couple questions from the audience, and I haven't prioritized them yet, so it might take me a moment. But just really quickly, have there been studies on male contraceptives in non-U.S. countries? It'd be interesting to understand the interest men have on male contraceptives across different countries and with different healthcare policies than the U.S. So I know a little bit about this, but I know that some of you know a lot more. So anyone who wants to jump in about those international studies or multi-study sites, please share.
Yeah, that's a great question. And I would say a lot of really seminal work has been done in China and India. And there's been contraceptive studies in Australia and in Europe. And the one that Brian and I just participated in was done actually in 17 different countries. So I would say internationally, there's a great deal of interest. The WHO has been a prior funder of a lot of this work as well, and probably did 3 of the most important male contraceptive studies. So I would say there's broad international interest. Now, that's historically. What's going on in China right now, things have changed quite a bit. I have a colleague in China who, they basically can't get the funding that used to be there for contraceptive work is no longer there because they have a lower rate of reproduction right now, below replacement, and the government is quite concerned about that. So we've gone from a 1-child policy in China now to a 3-child policy.
Right.
So it's a shifting landscape. I think what your question is getting at is a little bit is not just what's been done, but what are men's attitudes across the different countries? And that's a really interesting question too. I'm actually going to punt that one to Brian, who's sort of our local expert on, contraceptive acceptability.
Yeah, I mean, as you'd expect, right? Wide variations across different countries based upon different cultures. What I was trying to do in some of my work is better understand that what is the thread that ties all things across cultures, and that I would say is gender equity, and this concept of what are men's roles, what are their responsibilities in various other settings. And what you find is that in countries where there are greater scores for gender equity, there's more interest in male contraception. So the U.S. actually is actually not rated as one of the highest gender equitable countries, and that kind of also is evidenced in some of the U.S. population surveys about male interest in contraception. So our greatest interest really comes from some of the European countries, lowest in Indonesia, and some sub-Saharan African countries as well. But the silver lining of this, right, is that this is all changeable, right? So as we evolve, or as we progress societally into more gender equitable focus, which there are multiple groups and multiple people, I think, on this call in the audience who have worked in gender equity. As we build on those interventions, I do think that we are affecting the direct landscape for male contraception.
Mhm. Yeah, and as Brian is emphasizing gender equity, I'll give a little anecdote from a project that I ran in Rwanda where we scaled up vasectomy services across the country. And in that study, we found that in the project, we found 2,300 men over a couple of years who got vasectomies when the rate was super low prior to that. But when we asked those men how they learned about vasectomy, most of them said through their wives, like 70, 80%. But when we asked them why, what were some of the motivations, not just to limit their family size, but a lot of them reported that their motivation was behind what that was behind it was related to their wife having difficulties with hormonal contraceptions, right? And this implies a couple of things. There's one is that, we know that women, the research is there that women have challenges with hormonal contraception and method switch often as a result. Which the method switching can provide windows for unexpected pregnancy. But also, it implies that those couples have a different level of communication about this really intimate topic, right? And that's key around the gender equity components, being able to have that kind of conversation, and also like him taking in a country where vasectomy wasn't that common before. For this guy to go in and get the vasectomy, kind of talks a lot about the relationship and the quality of that relationship, and how they speak to one another. So kind of that gender equity element is always going to be that within these projects as it kind of moves forward. I think it's really key to keep in mind. So going back to the board here. So one of the questions was back to advocacy, I think, is how does male contraception and advocating for it fit in with the rising pronatalism movement, and how do we speak about that in context? So I know we talked about this, touched on it briefly. It's a little bit tricky of a subject, but maybe if you're willing to do your best on it, or maybe how you might approach it in a clinical setting with a client, or if you were to write about it, in terms of what would you be focusing on? I've heard a little bit about information before, but yeah, if anyone wants to share more about that, that would be great. Because I think the audience is looking for
Yeah.
resources,
I
right?
think that's a very thoughtful question, and one that we think about a lot. I mentioned the experience in China, which is now becoming more pronatalist as they worry about their demographics. I usually talk to people when I say I work on contraception. I'm trying to prevent unintended pregnancy, which is the main cause of abortion.
Yeah.
I'm actually pro-family. I do a lot of fertility research and a lot of fertility treatment. So, in my mind, at the end of the day, it's really about helping people who don't want to have a pregnancy not have a pregnancy, and helping people who want to have a pregnancy have a pregnancy.
Right.
So that is how I reconcile that. But I appreciate that question.
Yeah. Anyone else?
Yeah, I mean, I think yes, what John was just talking about, the timing and spacing piece is something that we don't talk about often enough when it comes to contraception. Um, Pregnancy spacing matters a lot for health and for birth outcomes. And it also matters a lot for economic and social outcomes. And using contraception doesn't mean you're going to have fewer kids in your lifetime necessarily. It may just mean you change when you have those kids. And having more choices to make those decisions easier, to make those decisions, to actually be able to have that control when you want that control. Because contraception fails, and the more methods you have, the more options you have, the more likely you're going to be able to find a method that will work well, that won't fail for you. And I think a lot of these new male contraceptive methods have that possibility there. The pronatalism piece has come and gone over the years. It is something we have seen. This is not a new thing in the United States, certainly not a new thing in the world. The pronatalist policies don't work, unless they're extraordinarily coercive, like a one-child policy. They barely move the needle otherwise. The U.S. already is extremely pronatal in terms of many of its policies, including its tax policies. And what's really causing the problem is the anti-immigration piece at the moment, because it's been immigration that has kept the U.S. well above the replacement level in terms of population. And you only need this pronatalism if you are also anti-immigrant. None of that helps in terms of how you fight it, of course, because a lot of that is just purely ideological, and it's pretty hard to persuade people who are down a conspiracy theory well, as many people on the pronatal side really are, unfortunately, at the moment.
Yeah. Yeah. And I think I heard in our previous conversation, one of you mentioned that fertility rates were kind of at their lowest during the Great Depression. So economic kind of prosperity and kind of the outlook that people have, for their families in the future is definitely an implication. It has implications for fertility and family size and number of children that you expect to have. So, if your outlook on the future is critical to your reproduction, right? And so, yeah, keeping the economy moving is pretty key. So,
Oh, and we see that definitely right now in terms of why young people say they don't want to have kids or want to have fewer kids. They talk about the state of the economy. They talk about their own personal economy. They talk about, things like climate change and the state of the world. You want people to have more kids, the world a better place. Convince people that the world is a better place and that their kids will have a future and they'll be much more likely to have kids.
right,
Well,
right.
well said, Adam. Thank you.
Anyone else? Okay. Brian?
No, I'm
All
gonna
right.
capture it great.
Okay. Yeah, so I think one of the questions is around, like systematic screening for women interested in contraception has been applied in many countries. And maybe the host session that I had been talking about earlier was about what seems similar and could have potential to increasing men's interest in and knowledge about contraceptives. So do any of the speakers exploring adopting this or in their clinic space, this approach for health settings of all kinds that men frequent? Or how can we kind of increase and elevate that conversation either in the clinical space or in the medical conversation or materials that are out? I mean, I always go to WebMD when something's wrong with me first. I know that's not what I'm supposed to do, maybe. I don't know, but I'm kind of like that guy. And, so give us some ideas that you all might have around kind of elevating the conversation.
I have one thought about that. I don't have a lot of data on this, but I went to a meeting where people were talking about using the screening question, how would it be for you to have an unintended pregnancy in the next year? For every person who walks in the door as a gateway to having the conversation about contraception. This was for women. I would
Yeah.
love to see a study where we actually did that for men as well. And I think that would be a really good way to sort of start the conversation. That's not a screen as much as I guess it's a screen.
Well, it's also framing and letting somebody get the image in their mind of, oh, I should be
Oh,
thinking about this a little bit, right?
right,
So,
right.
or maybe if they have had a vasectomy, maybe they're like, that would be an act of God if I had a baby now. So that'd be a
Would be
whole
a
other thing,
surprise.
right? Yeah. Anyone else?
Yeah, I'll add that. I actually want to do that exact same study because the one key question is very often used in reproductive health clinics for women. And the alternative when someone says, I actually do want to be pregnant, right, is that we then connect them to, preconception care. And there's actually a nice,
Absolutely.
algorithm for what screenings we should be doing, what testing we should be doing, and what things we should be talking about. The issue, though, is that we don't have an equivalent for men, right? So if a man wants to prepare for pregnancy, I'm not fully sure what are the guidelines for that. I have a sense, right? But they're not consensus. They're not evidence based. And
We
a lot
need
of
to
the research is
study that.
undeveloped. Right,
Yeah, I
right.
think there's emerging data in the male field that the epigenetics of sperm are quite important for the health of the offspring. So whether or not having a man take folic acid or stop drinking or stop using marijuana in the preconception period actually benefits the offspring is an interesting question, Brian, but we don't
Yeah,
have the data right now.
I mean, emerging data also on men's obesity impacting on placental development.
Obesity. There are a lot of things that
Right.
potentially could adversely affect the genetic integrity of the sperm.
Yeah.
Yeah.
So I'll add to the previous part of the conversation around, like, we've done some community work where we've tried to work with community clinics to introduce more questions and engagement with men around sexual and reproductive health. It was quite challenging to get buy-in by the clinicians. They're mostly internal medicine docs who are dealing with these chronic issues for most part, and it was hard. It was really sort of this block about, why is this important? It's like, why should we talk about it? So I think we're challenged, but we need to figure out a key to help that to happen.
Yeah. You know, it's interesting too, like culturally, we're seeing this as, you know, recently there was a internet kind of TikTok sensation around this sperm race, which wasn't really a sperm race, it was a cartoon, but they kind of build it all up and these kids raised a bunch of money and all this kind of stuff. But the, you know, that conversation is happening, and this also within the manosphere, one of the pieces of the manosphere is around the your sperm quality. And more recently there was even a comedian named Andrew, is it Andrew Schultz maybe, who had a Netflix special, and the Netflix special centers on, it completely centers on the role of himself and his sperm quality in terms of getting his wife pregnant and his experience
Oh,
going through.
somebody put that in the chat.
Yeah, it's on Netflix for sure, and it's Schultz, Schulz, I think.
Excellent.
And so yeah, he's a bit crude. I'm not gonna say like, you know, it's very crude, but it's also, I think it's very informative too, because it gives a language around the space
That's
that,
great.
you know, where men are talking about this and he's making jokes, but it is also very intimate moments in there where he
Mm.
crosses over and he says, you know, this is the moment, this is my kid, this is my wife was experiencing this, but really, you know, all the tests in the beginning were her, but then they found out the problem was him. And so what does that mean
All
to
too
him and
common.
his masculinity and all of those things? So as this conversation, we need to capitalize on some of these pieces too in these moments, and like maybe normalize that conversation around, you know, contraception or proception, or I guess conception, in our society as well. So
Hey, just to add to that, I
yes,
know that there are
please.
probably some, some students and who are who are part of this call. A great project, right, would just be to gather in one space all of the public figures, comedians, celebrities who are actually just talking about their fertility issues or their male sexual reproductive health issues, because it's relevant. And I think you'll find that over time, more men are coming out with their stories about needing to see a fertility doctor or just having concerns about parenthood, unplanned pregnancy. Um, and it just is going to help to make more evident that this matters to men.
Right. Yeah. And that mattering to men is central to to the success of this space. I think with that, I think that I know we have a few extra minutes. I don't know if anyone has more to add. I'm seeing some repetition in the questions. I don't know if there's one question anyone is focusing on answering. There's more questions around studies. We can provide some of the research, and also the Male Contraceptive Initiative has pages of links
Mm.
to many studies that not only they have supported, but other institutions like other foundations and things have supported the implementation of those. There's a few marketing and studies that have gone out. There are studies that are happening right now with Contraline and also with you know, other methods that are underway that people are paying close attention to in the space. Um, and you can find a lot of that information from the Male Contraceptive Initiative. Um, so I think with that, I think we're at a good stopping point, and I think we're gonna share a ton of resources. If you signed up for this, you're gonna get an email with both a recording of this session. We'll send you the image that Terry put together for us. And we'll send you a bunch of links and resources to different studies, research articles, you know, thought pieces. I wrote a blog on that Andrew Schultz piece. I'll send it to everybody too. You can watch it
Please.
on Netflix, and hopefully his language isn't too much for some of you. and I really appreciate everyone being here today. Our expert panel this is great. A panel of, you know, the last one we had a bunch of women on it too, but good to have a group of guys talking about this and advocating for it in a way that is, you know, both, I hope people can take some language away from this conversation and also put it into their own experiences and the things that they're advocating for around contraceptives and reproductive health. So thank you all very much. And with that, I'm going to pass it back over to Holly, and you guys look for the email from us in the documentation as it comes out.
Before you go, I just want to say thank you, Dominick, for organizing this, for moderating it. It was really, I learned more than I learned a lot more than I thought I would. That was really outstanding. And thanks to the sponsors, I think Hopkins and MCI in particular, and I'm sure there were others.
And essential to that are two people, which are Holly Hong, and who's on this this organized webinar in terms of the logistics, and then Deb Levine, who was a real thought leader in this space for us as we kind of pulled this all together. So yeah, I appreciate the thank you, and it really goes to those guys. So all right, thank you all.